fine. I think we can start.
Catherine, do you know if the only person in the session is Mar? Ah, there she is. Perfect.
Oh, good. Well said.
Yeah, sorry about that. That was this was the link that was sent to me to get here. So.
Yeah, no, it's not a big deal. And we actually, that usually happens. It's because the panelists sort of get a secondary link. The main Zoom event link is what's coded into the conference session. It happens. Glad we figured it out.
Yeah, no, thank you. And somehow my email address was wrong too that you guys had. Either way, I'm here. Hi, thank you.
Hi, Heather.
Hey, hi, Heather.
Just a heads up, Katie, I don't know if you can put this into the chat from time to time. If there are any questions regarding Department of Health or services sent to or services provided by the Department of Health, if you could just provide them with my email, and then all those questions can be referred to me through my email.
Your email. Sure.
Yeah, perfect. I appreciate it. Sorry, I'm not too sure if I was able to talk to you about that. I got a number of volunteers that were texting me today.
No, you're good. Yeah, I'll share your email once we get started.
Perfect. And then I'm not too sure if there's a way, if we aren't able to get to all the questions today, if we will have a list of them and we can, if the person wants to contact us or whatnot, we can get back to them.
Yeah, we can leave the chat up because I think after this, there's like a 15-minute break. So if they want to stay and chat a little bit, they're more than welcome to. And then we can also share contact info with them if in the chat if they want to email you with any questions.
Okay. And then in the beginning, I'll just go ahead and say that if there are any questions regarding the broader Department of Health or anything, that they can email me. But our questions are.
It's open to everyone right now.
Oh, perfect. Everybody can hear me.
Yes, all the attendees can hear, yes.
Good.
Okay, so briefly, my name's Katie, for those of you who don't know. I work with AHEC, so if you have any of the speakers have any questions for me, feel free to contact me. Should be going really smoothly. So the participants, so we're like, okay, we're on now. Okay. So who will be speaking first? Is that, I have Heather Lusk first on the opioid list. Will you be speaking first?
The order will be Katya, myself, then Heather, then Andrew.
Okay. You folks would like to do your own introductions, or would you like me to introduce you real quick?
We can introduce ourselves as we go.
All right, sounds good. Okay. So welcome everyone to the Opioid Initiative, Hawaii Opioid Initiative update. We're just gonna go ahead and get started.
Perfect. Hi, everyone. My name is Katya Worley. I am the State Opioid Coordinator for the Hawaii Department of Health at the Alcohol and Drug Abuse Division. I'm also the Grant Project Coordinator for the Substance Abuse and Mental Health Services Administration State Opioid Response Grant, and the Coordinator for the Hawaii Opioid Initiative, which we'll be talking to you about today. Just a little reminder, if you have any questions regarding the Department of Health in a general or any of the programs that we provide, please send them to my email, and my email will be provided to you throughout this presentation, and we can go ahead and move on. Perfect. Today, the speakers that you'll be hearing from are me, Katya Worley, Catherine Burke, Heather Lusk, and Andrew Abe. And today for our agenda, we're going to talk about the overview of the Hawaii Opioid Initiative, the 2020 HY Evaluation Report, preventing opioid overdose with access to naloxone, the naloxone survey for pharmacists, and the media campaign. So the Hawaii Opioid Initiative is a multifaceted approach to opioid use disorder, or OUD. Currently, there are 193 volunteer members from 106 organizations. And the Hawaii Opioid Initiative will be entering its 4th year of implementation. The initiative was launched in July 2017 by Governor David Ige in response to the national opioid crisis to develop and implement a proactive, coordinated statewide action plan in order to avoid the tragedies experienced in other parts of the nation. The Hawaii Opioid Initiative takes a multifaceted approach again to a large public health issue and has presented an opportunity to bring together many organizations, stakeholders, and systems to address the needs of the state regarding OUD and other substance use. So I'm going to tell you a little bit about the different components that make up the Hawaii Opioid Initiative. Again, there are 106 organizations that are represented in the Hawaii Opioid Initiative across 7 different focus areas. So the first focus area is treatment access, and it works to improve and modernize healthcare strategies and access for opioid and other substance misuse treatment and recovery services. One of the projects that came out of this focus area was the Coordinated Access to Resource Entry System, or Hawaii CARES, that was launched on October 1st, 2019. Hawaii CARES exists to provide a continuum of care to deliver substance use disorder treatment modeled after the American Society of Addiction Medicine criteria for SUD services. Historically, SUD treatment programs in Hawaii have operated independently of each other, offering limited or little coordination of services without ensuring that client care shifts freely between levels of care as clinically appropriate. CARES intends to provide a redesigned, coordinated, and responsive system of care that provides clinically appropriate substance abuse treatment and recovery support services statewide. Services need to be on demand for those who need it, when they need it, and where they need it. Focus area 2 is prescriber education, which works to improve opioid and related prescribing practices by working with healthcare providers and payers. One of the projects that came out of this focus area is MOCA Minutes and Project ECHO, which are some of the projects and have come out of this work group, to encourage continued education within our prescriber community. Some of the other objectives of this work group also included increasing primary care provider pain management practices by 25%, increasing prescription drug monitoring program utilization by 10%, and enhancing the PDMP, which is the prescription drug monitoring program. Focus area 3 is data-informed decision-making, which works to implement system-wide routine data collection, sharing, and dissemination to increase knowledge and inform practice. Much of the discussion in various work groups centered around the need for data to make decisions. However, the data work group recognized that while data is needed, a more pertinent need is for a standard way of collecting, synthesizing, and disseminating data. Can you all hear me? Yeah, okay. I can talk louder if that's okay. The act of gathering more data, while helpful, does not benefit decision-making if it is not processed in a way that informs policymakers. With that being said, the Department of Health, the Emergency Medical Services, and the Injury Prevention Services branch, apologies, are working together to bring data systems together and analyze relevant data to drive our projects and objectives for the Hawaii Opioid Initiative. Focus area number 4 is public education and prevention, which works to improve community-based programs and public education to prevent opioid misuse and related harms. They implemented year-round Dropbox sites in coordination with Work Group 6 throughout the state. You can find a complete list of Dropbox locations on our website, and we'll show that to you later. They're also working to develop training mechanisms for certified substance abuse counselors, certified prevention specialists, adolescents and school-age youth, teachers, home health care providers, and others who work with populations at risk for opioid misuse and related harms. In addition, the work group developed a website, social media, and media campaigns that include PSAs and other advertisements. Focus area number 5 is pharmacy-based interventions, which work to increase consumer education and prescription harm management through pharmacy-based strategies. Access to naloxone is nationally and universally recommended practice, and has been shown to reduce the incidence of opioid deaths due to overdose. That being said, Work Group 5 worked to support Act 154 relating to opioid antagonists, which puts into law allowing pharmacists to prescribe naloxone. And the work group continues to develop and disseminate guidance on how to prescribe naloxone and to provide education for pharmacists. Focus area number 6 is law enforcement and first responders, which coordinate services and increase specialized training for first responders and work to implement effective laws and policies. They implemented take back boxes with work group 4 at a number of police stations across the state and worked to develop standardized training for first responders. Our last focus area is SBIRT, screening, brief intervention, and referral to treatment. The main focus of this work group is to increase SBIRT across the state. They work with MedQuest to standardize and implement statewide SBIRT training and technical assistance. Each focus area has a work group that identifies and works on the set of objectives each year. As the Hawaii Opioid Initiative continues to grow and adjust, they continue to grow and adjust to meet the state's needs. We can move on to the next slide. Perfect. In this graph, you can see the top 4 organizations that have the most representation in the initiative. That is the Department of the Attorney General, JABSM, University of Hawaii, and the Hawaii State Legislature and Queens Medical Center. Next slide, please. In this graphic, even though there is a concentration of representation in Honolulu County, there is representation from across the state, and we work to really increase that representation to get a better picture of what is going on throughout the state. Next slide, please. And lastly, over the course of 2019, there were a total of 47 meetings held across the 7 focus areas and 10 operational work group meetings. And the operational work group was comprised of all the co-chairs. It is important to note that work group 6 met once in 2019 due to the service on Hawai'i Island, and right now they're on hiatus due to COVID, but we are still in contact with them and they still continue to work with us. Thank you. Next slide.
Thank you, Katya. Can everybody hear me okay? Thank you. My name is Catherine Burke. I'm the lead evaluator at a University of Hawaii-based evaluation team located at the Pacific Health Analytics Collaborative. We're a lab working for Victoria Fan. We're located at the Myron B. Thompson School of Social Work in the Center on Aging. And so I just wanted to share an overview of our evaluation report for 2020. And I'm going to begin by sharing our website. And so I think Katya will share a link to the report in the chat. So stop share. So recently, on August 31st, we released our first iteration of this living document. And we also completed the evaluation for last year from 2019. So this is building upon that. If you go to the link, you can see a navigation bar at the top. It is a 109-page report with almost 30 infographics. So for this presentation, we're just going to take a deep dive into one aspect of the HOI. But I did want to provide an overview that the report has an introduction, an epidemiologic landscape, which includes a Hawaii-focused data dashboard from the National Survey of Drug Use and Health. There are the scorecards, which are based on this HOI strategic plan, evidence-informed strategies, achievements, overall successes, challenges, and recommendations. So just to give you a sense of the website, as you scroll down, there are various infographics that you can scroll through. So I'm going to go back to the slide, and we're going to take a look at work group 3. Resume slideshow. So we have scorecards to help us monitor our progress on the HOI objectives. And so you can see in the first year, there's relationship building with the Narcotics Enforcement Division. And today I'm going to focus on this HOI 2.0 status update for objective 3.3, which is by October 2019, increase prescriber education regarding access to and use of the PDMP, including delegates by an additional 20%. And then this objective ties into the current objectives, which are HOI 3.0, and then we'll move on to 4.0 for next year. So For our evaluation, the one role for our team is to monitor the logistics of all of the meetings. So for the 47 meetings, we provide agendas, minutes, manage the Zoom, as we're all mostly on Zoom nowadays. And through the minutes, we were able to assess progress on all of the objectives. So when you go to if you go to the website, navigate through these achievement section scorecards, which were prepared by our students, you can see a status on each one. So there's objectives completed for work group 3. They have completed the following objectives, and then there's some in progress. So I wanted to highlight objective progress related to the PDMP. Progress is underway. And you can see a quote. So in addition to reviewing documents related to HOI activities, we disseminated a survey to the HOI and received 24 responses. And of the successes that were most relevant to one of the members, they did highlight that lobbying for changes to the PDMP was an important success for them. Policy, we also track legislative advocacy and progress. So policy continues to refine the implementation of the PDMP. Currently, moving around our faces, we have 90% of current PDMP utilization from registered users. And this year and moving forward, work group 3 is working towards utilization of the PDMP to document naloxone prescribing and dispensing from retail pharmacies, which Andrew will share a little bit more about later on. So once again, the PDMP gathers data on selected controlled substances dispensed to patients. When linked to other data sources, such as death records, the prescribing patterns for individuals who have died from an opioid overdose can be assessed. Only the PDMP data source can reveal if a patient is dispensed controlled substances by multiple providers and multiple pharmacies. So in order to set a foundation for the context of opioid use disorder and overdose in Hawaii, we are referring to data presented by Dan Galanis from the EMS, Emergency Medical Services and Injury Prevention Branch. And so this is his data. So I'm just going to walk through an example. So in 2016, he has extracted data from the PDMP showing that there were 70 decedents or deaths identified through the Honolulu Medical Examiner records. Of those 70 deaths, there were 3 that were heroin only and had no link to the PDMP. Among the 67 victims that were positive for at least one type of prescription opioid, including methadone and morphine, 16 had no link to the PDMP, so they're not registered. 51 were, and so they had a link to the PDMP. Of those 51, 2 of those had no opioid pain prescriptions registered in the PDMP. And so the next chart will just demonstrate of these 49 people that had a record of prescription opioid in the PDMP. And I'm sorry, I'm not monitoring. Let me take a look at the chat. I see it blowing up.
I got it, Kat.
Okay, great. Thank you. Okay, so of these 49, we were interested in understanding the time between date of death and last prescribed access to opioids. So among those decedents, it was for 24, 0 to 6 days. So this represents the total number of opioid prescriptions that varied widely from 1 to almost 200 among victims of fatal opioid overdoses in Honolulu County, so just on Oahu in 2016. So you can see that there's the majority of this subset was between 0 and 6 days of picking up their prescription. 9 was between 1 week or 3 months, and 16 was 4 months or longer. So again, for our evaluation, what we hope to do, because the HOI is taking such a broad look at our healthcare system, is reflect back how these different data points are interconnected and provide opportunities to think differently about the problem so we can continue strengthening the continuity of care. And in this case, it is possible, one possible direction for the HOI could be to look at when people are receiving opioids for the first time, maybe they can receive more information about naloxone, and this can be a way to guide the naloxone distribution and training plans of the HOI. And so without further ado, Heather Lusk is going to share with us about that process.
Thank you so much, Katia. I just saw a note in the chat. I mean,
Mhm.
Kat, sorry.
Mhm.
Katia, did you see that note in the chat about, can folks see the screen? Because there was somebody who said they couldn't see Kat's slides. I just want to make sure that folks can see again. So if you could, if a couple folks could put it into the chat box, and then I'll have Katia try to help us with the tech. So thank you so much, Kat. And I have to give particularly Kat props because she supports work group number 4, which I'm blessed to have just finished my 3rd year of co-chairing with the fabulous Thaddeus Pham. And Kat has been and the whole UH team have been incredible. I've been doing this work for 25 years just to date myself. And this is seriously the most effective interdisciplinary task force group that I've been a part of, and I'm really proud to be here today to talk specifically about naloxone. And my name is Heather again, and I am with the Hawai'i Health and Harm Reduction Center. So next slide, please. Thank you. So as you may know, on the continent, particularly, somebody dies of a drug overdose every 8 minutes. We're blessed in Hawaii to not have that high. We are actually 49th out of 50 states for opioid-related overdose. We have more people, not surprisingly, die of meth-related overdose. And I think one thing about the Hawaii Opioid Initiative is that it's really provided a foundation to address all substance use. And you'll be seeing a pivot from the HOI to include methamphetamine, just as the feds have done so in ADAD. And so we're really grateful for those of you that will continue with us on the journey to help us take lessons learned and apply to meth. Yeah, next slide. This is the latest data from the Center for Disease Control. And as you see on the reason I'm showing you this data, and I'll show you Hawaii's a little bit later, the highest one is actually from fentanyl and other synthetic opioids. And what that shows is that we in Hawaii and on the continent have done a great job of reducing overdose deaths from prescription medications. However, as we have put in things like PDMP and other efforts, it's done some really great work, and we've had the unintended consequences of people with underlying opioid use disorder getting kicked off their pain medications, going to the street and getting things like fentanyl. And now we're seeing a lot more deaths from fentanyl and not the prescription meds. So we have to be careful about that unintended consequence. Next slide. But luckily we have the life-saving drug naloxone, which is currently still, you need a prescription for. However, the FDA, many think, are very close to making it over the counter. They've had several meetings about that. So what is naloxone? It reverses opioid overdoses by blocking the receptors in the brain that opioids bond to. There is no abuse potential. You cannot get high from it. It could put people into withdrawal, especially those who have opioid use disorder, because they're going from having a lot of opioids to none, because naloxone blocks that. And it can be administered a wide variety of ways. The one in Hawaii is through the nasal passages and intranasally. You can also do injection. And there's also a fancy pen that can talk you through how to use it. It lasts about 30 to 90 minutes, and that's important to know because especially for some of your opioids like fentanyl that are much stronger, it may take another dose of naloxone, and or somebody may go back into an overdose after the naloxone wears off. So as you'll see in a moment, the best practice is to still call 911 even if somebody is revived from naloxone. You can repeat it. Next slide. And there is really, again, no harm in the literature. It shows very few adverse consequences other than maybe going into immediate withdrawal. So if somebody is not having an opioid in their system, it will not hurt them. It will not help you with an overdose from alcohol or benzodiazepines or stimulants. It's only going to help in an opioid overdose because, again, it blocks the opioid receptors in the brain so it doesn't absorb into the body and it has an instantaneous effect. I've seen somebody go from not breathing to alive in moments of seconds with the administration of naloxone. Next slide. So I'm sure most of you here have heard about naloxone, and we'll give you an update on what's happening in Hawaii through the Hawaii Opioid Initiative. This is actually Surgeon General Adams last year, and yes, it is the back of Lieutenant Governor Green, and that's my staff, Hana, and the Lieutenant Governor and the Surgeon General visited our program to learn about our naloxone program because the Surgeon General has been a big advocate, and this is his statement saying that because it's so safe, and there's really no adverse consequences in the literature, get it out there. Now, it's not the end all be all. I don't want to say that you don't want to learn CPR and other life-saving measures, but it's something that can be part of your arsenal, especially if you may be around somebody who could be at risk of an opioid overdose. Next slide. That's the one that we use in Hawaii, thanks to Katia and the Hawaii Department of Health. If you want to get this free, I'm going to give you information to do that through our program. Again, we get it from ADAD at the Department of Health, and this is the exact kind that you will have, and we'll teach you how to use it. Next slide. The steps in a real nutshell is that we test for unconsciousness. We ask someone to take their hand like this, do what's called a sternum rub. If someone's experiencing an overdose, they may not be able to respond. Otherwise, ow, it hurts, so I'll respond. Then we tell the person to use the naloxone in the nasal passages. It will work even if they're not breathing because it absorbs into the mucosa. And then we recommend rescue breathing until 911 shows up. And then of course the recovery position in case the person gets sick. So this is what we teach folks when you come to get naloxone from our program, and what the pharmacist will be teaching you if you get it from the pharmacy. Next slide. So I asked Dr. Dan Galanis, who is, I think, a data superstar, what's going on in Hawaii with overdoses. On the continent, COVID is causing a huge increase in both fatal and non-fatal overdoses. Well, in Hawaii, we have been resilient and blessed. We are not seeing, so if you look at this slide here, the purple is the drug overdose. This is January 1 through July 7th, 2020. So it really holds before COVID and all the way through, until a couple of months ago. And it's probably not surprising that motor vehicle accidents went down because we were all staying at home. But unlike the continent, people staying at home and relapsing or going into withdrawal because they couldn't get their drug and then using too much, or masking their pain or self-medicating, we didn't see overdose deaths rise, and that's a real success to many of the people here today, and definitely to the Hawaii Opioid Initiative. Next slide. We have three main acts and now laws in Hawaii that you should know about if you're not familiar already. Act 217 from 2015 allows people to call 911 in the event of an overdose without fear of arrest if the only law that you're breaking is being around the drugs and the drug user and not having any other warrants. The other two are the ones that really allow us to have increased access, and the Hawaii Opioid Initiative has made that happen. Act 68 that came out in 2016, we just hit our 4-year anniversary, and that's allowing agencies like mine and others through standing orders to have naloxone and to distribute it. It gives broad immunity to those of us that carry naloxone, use naloxone. It gives that same immunity to first responders. It recovers Medicaid coverage of naloxone, and that's how our pharmacies can be a huge player in our public health response. And it requires the Department of Health to collect data on overdoses and report back. So this is really, again, we have one of the most progressive in the country that really allows people access through these training. And again, props to the Alcohol and Drug Abuse Division and DOH for really ensuring that people have access to this life-saving medication. And then lastly, Act 255 allows pharmacists not just to dispense, but actually prescribe naloxone. And August 31st, which was Overdose Awareness Day, they launched a new initiative on the website that we can briefly show you to share the information and all the ways that pharmacists can get certified to do naloxone, as well as link people up to their local pharmacy that has naloxone. And if there's a copay, you can come through our program. Next slide. So our program, again, was launched 4 years ago. At first, it was in collaboration with the John A. Burns School of Medicine and Dr. Tricia Wright. We're so grateful. She left the islands recently, and now it's under Dr. Christina Wang, the medical director of the Hawaii Health and Harm Reduction Center. We have distributed over 10,000 doses of naloxone statewide, and I'm so proud of all of our partners. That's included everybody from the Maui and Hawaii police departments to Gary Abuda and the high intensity drug trafficking, narcotics enforcement, our law enforcement partners, and many of the treatment centers around the islands, as well as our homeless clinics. The other big piece is that we train people still actively in their substance use disorder so they can save each other. And as you see here, we've had 6,000 doses go through that program, and we've had 296, so just under 300 reported reversals. You saw on the slide earlier from Kat that the heroin-related overdoses are dramatically down, as are the fentanyl in Hawaii. We don't know for sure that it's because of these 10,000 doses of naloxone, but the data indicates that's a good reason why. As I said, we've had 296 people come back to us and say, I used it to save a life. And if you aren't one of those people that already carries, you can follow up and again, be one of those people, because you never know I think my favorite story is somebody who happened to go through this training on Maui for work, but then actually saved her grandmother because her grandmother had a prescription for opioids because she had cancer. And because of some also early dementia, she didn't remember how much she had taken and overtook them. And her granddaughter happened to be there with her naloxone, and EMS said she saved her life because she was out of, wasn't in Wailuku. It took a while for EMS to get there. And that grandmother is alive today because of this young woman having naloxone and acting quickly. So you just never know. In Hawaii, it is our kupuna that have the highest rates of overdose according to the Department of Health. Next slide. So again, how do you get it in Hawaii? On the left-hand side, you see from our pharmacist, we do require coverage. If you have Medicaid, there still may be a copay depending on your plan. And again, the pharmacist can prescribe it right there. The recommendation is if you have a regular prescription for pain medication, excuse me, you should also get a naloxone just in case there is an overdose. And I have the HawaiiOpioid.org website there for more info. The other option is, thanks to Department of Health, you can contact us. We're actually mailing you naloxone if you can come to a training online, which is free. We have our website and our phone number up there. We have trained literally a couple thousand people now, and it can be everybody from the person themselves that are at risk to loved. And even though methamphetamine and other substances may be more of risk, this can be an incredible doorway to have that conversation just about overdose in itself, especially because polysubstance use and relapse or a period of abstinence like incarceration are the biggest reasons that people do die of overdose. In fact, in Hawaii, Dan Galanis found in our data that there was a high percentage, I think 43% of people who died of an opioid-related overdose also had a benzodiazepine in their system. So the more we know about this, the more we can target. And again, we have made these strides and hope that you can join us to learn more about naloxone if you don't have it already, and help us save more lives, because nobody needs to die of an opioid-related overdose given this safe medication. Next slide. These are some websites. Prescribetoprevent.org is for your healthcare providers. They have examples of prescriptions and standing orders. There's a whole pharmacist portal made by and for pharmacists to show you policies from other states. So for healthcare providers, we recommend the prescribetoprevent.org. You can get a certificate to be trained in naloxone from Get Naloxone Now. And again, please visit hawaiiopioid.org. /prevent overdose to learn more. And of course, feel free to visit the Hawaii Health and Harm Reduction Center to sign up to get trained and get naloxone delivered. Really appreciate the opportunity to speak with you. And again, join us on the Hawaii Opioid Initiative. It's an incredible experience. And now that we're going to be taking on methamphetamine, we really need all the mana'o we can get in strength. So with that, I believe that I'm turning it over to Andrew from here. Thank you.
Aloha, everyone. My name is Andrew Abe. I am a pharmacist. I serve as one of the evaluators also on the Hawaii Opioid Initiative. And today I'm just going to chat a little bit about one of the surveys we had in order to gather more information of what's really going on in the state of Hawaii in regard to pharmacists and naloxone. Can you go to the next slide, please? So again, what we kind of have in Hawaii, kind of what, going off what Heather was talking about, in 2019, we had Senate Bill 535, which replaced the old acts, which allowed pharmacists to prescribe and dispense naloxone to anyone, regardless of who they are, whether they're at risk or not. And this is important too, right? Because pharmacists, as you often see, they are highly trained and they are easily accessible in the community setting. For pharmacists to prescribe and dispense naloxone at point of sale in a pharmacy, they do have to go through additional training as well too. That training was created and is hosted by the University of Hawaii, Daniel K. Inouye College of Pharmacy. So what this survey was, again, was sent out to all members of the Hawaii Pharmacists Association, again, to kind of gather information regarding the comfort level and what's going on with naloxone dispensing since 2018. Out of the total number of people who we emailed out, 18 people responded. You can go to the next slide. What's great about our survey response is that we got a great collection across all different specialties within pharmacy, specifically what we are looking for in the retail pharmacy and the community setting, as well as hospital inpatient and outpatient setting. Next slide. Of course, the majority of our participants were from Oahu. Interestingly enough, too, if you take a look at the right, where it looks at did they dispense naloxone in the past 30 days, a majority of those pharmacists that replied that they did not dispense naloxone in the past 30 days. Next slide. So when we take a look at this graph, it's a little busy, so I'm gonna go ahead and go from left to right. If you take a look at the left, one question we had to the pharmacist were, how comfortable are you with screening and dispensing naloxone? Now, these questions dealt with more the clinical aspect of dispensing it, interviewing the patient and dispensing appropriate naloxone to the appropriate person. As you can see, a majority of respondents were either comfortable or very comfortable with this. But as we take a look to the right, as we right shift it, where it looks at comfortability with documentation and billing, as you can see, a lot of those respondents who responded with comfortable or very comfortable shifted to more uncomfortable responses. And what this kind of looks like is that it may suggest that pharmacists are comfortable again with the clinical aspect, but in regard to the administrative parts, there's still some things that potentially we could help better understand. Some of these ongoing topics that we are still navigating are things like insurance coverage, quantity limits, how many doses can a patient pick up before they reject. Also things like Medicare coverage. Medicare allows you to only pick up for yourself. You can't necessarily pick up for others. But the spirit of the legislation is to increase access to anyone who requests it, regardless of who it's for. Also going forward for the pharmacists that do dispense naloxone, one thing to note is that right now they're not being currently reimbursed for their clinical services, only for goods dispensed. So the time they spend with patients aren't being reimbursed, so that may be another hindrance as well too. We do have pilot programs underway to look into if a modified expert model may be a potential benefit in regard to incorporating naloxone as well too. Next slide. Kind of like how we discussed, we did identify that there is a need for additional continuing education with our population. When we took a look at other states of how long it took to adopt legislation for pharmacists, it did take upwards of 2 to 3 years for the ball to really get rolling. And we want to make sure that we get the education to the right population. So what the Hawaii Opioid Initiative has done is take a look at where the needs are and hopefully moving forward, address those gaps with additional education. So that kind of wraps up what I had. Thank you very much. I'm going to go ahead and pass it back to Heather for the media campaign.
Oh, actually, I'm going to go back to the website. And hopefully the links that have been shared in the chat are now working. If not, maybe we can share that via email after the presentation. But I just wanted to share, let's see, where is it? Evidence-informed strategy related to pain management. And so, so when you scroll through, we had undergraduate students prepare literature reviews with the guidance of our graduate students and faculty. And so one of those speaks directly to alternatives to pain management. And so Andrew, if you could share with us a little bit about this, please.
Hi everyone, it's Andrew back again. Hello. In our initiative to ensure that our scope of what we're looking into regarding to opioids and opioid epidemic is that we, really investigate every venue. As part of work group 2, which takes a look at prescriber education, one of their asks were to take a look at potentially a subcommittee which looked at all venues of other pain solutions. So in regard to treating pain, alternatives, and we can scroll down to the bottom, it's okay if we can scroll through it. Recommending or even suggesting alternatives to pain management such as physical therapy, Tai Chi, meditation, or dietary supplements or natural products may be controversial to some. A lot of patients do seek this out, so it's important that our providers and our patients just understand what's out there and how to best incorporate this into their level of care. So we made these infographics in order to just potentially give some more depth into what's out there and just provide some support and understanding to what patients may be seeking out as well.
Great, thank you so much, Andrew. Again, I think that when Andrew was highlighting was really the interdisciplinary aspect of the Hawaii Opioid Initiative. I've always seen pharmacists as our kind of public health heroes, but this has really allowed them through their group to get that piece. So on the hawaiiopioid.org website that you see here on your screen, this has been one of the cornerstones actually of my work group number 4, but has now been a place that we can gather all information about what's happening in these different areas. So I don't know if you're actually able to show us the website, Kat, and we can show the Dropbox, for example. So you heard earlier when I believe it was Katia was going through some of the pieces, one of the things that we're the most excited about is that we went in Hawaii from only 2 times a year of having times that we could get rid of unused, unwanted, or expired medications to now having places all over the island. So if you go to hawaiiopioid.org/drug takeback, there's actually a nice map on there. I don't know if you can scroll down to show, but you can look and try to find drop boxes that are all over the islands. And if you click on each one of those, and it actually shows you the hours, where it's located, and what else you may need to know. And this has been an incredible interdisciplinary approach. It's been from the Attorney General's office on narcotics enforcement, the Department of Health, and then our local law enforcement, as well as our pharmacies. Because we have these drop boxes across the state in many of our police departments. And then we now have some pharmacies stepping up to have these. And as you know, there's some really major reasons we want to get rid of these. One, meaning have a safe place to dispose of these medications. One is that we don't want to pollute our beautiful waters, right? And anybody who dumps these in the toilet or our sewers goes right out to our water supply in the oceans. But even more so, we don't want them diverted to people. We don't want folks to find them in the medicine cabinet and try them out. We don't want folks to divert them and sell them inappropriately. So this allows people free to get rid of them. And so we really encourage you to learn about this and to find these sites. We still have these 2 national ones, the DEA takebacks twice a year, usually in April and October. I think we have one coming up. But now again, we have almost 30 sites statewide through the HOI, and we're excited because now soon we're going to use that same map you just saw to also put where you can get naloxone. And have the pharmacies that carry naloxone have a similar type map. And then the other piece is I'm really excited to announce that through the Overdose to Action grant, my agency in collaboration with others will ensure that there's other agencies on each of the neighbor islands and more on Oahu that also give out naloxone. So coming soon, we'll have the same map and have you give access to that. So also here on the website, as you see, is the pain management. We also have a quiz to say, are you at risk, that you can take to see if you're at risk for opioid use disorder, and really, again, try to collect all these different resources. Yeah, that was our first public service campaign of the HOI. We released that over a year ago, and we were able to reach thousands of people to take a quiz to see, if I got medications for pain or for any other reason that are narcotics, what are the signs, and when will I know if I need help? So on that, our most recent campaign is made by Hawaii's own Chad Owens. For those of you that don't remember Chad, he's currently a wide receiver in the Canadian Football League and was football with the University of Hawaii, and is no stranger to pain, and tells his own story about how his own struggle with pain led him down a path with a relationship with opioids that he wasn't expecting. So hopefully we're going to be able to share this with you right now.
You mask pain and you're actually damaging yourself more. Trust me, I've felt it the next day worse than it was prior to that game, and it's not a good feeling. We all have pain in different areas of our lives. And I think the best form of recovery is talking to people, talking to your loved ones. If no one knows that you're in pain, no one's going to be able to help you. Just know that you're not alone and there are resources out there to help you. If you or someone you love needs access to substance use treatment services, call Hawaii Cares today.
Again, we're so grateful to Chad for being willing to share his story. Part of what we're trying to do is break stigma. If this can happen to Chad, this can happen to any of us. And so again, if you want to learn more about his story, we also are going to have 12 news stories of your average, of people in Hawaii sharing their personal stories coming out in the coming month. It is a recovery month. And again, really appreciate everybody coming together to make the Hawaii Opioid Initiative a success. So on that, I am going to turn it back over to Katia to talk to you a bit about how you can get involved in HOI and help us take the next journey in the 4th year of this exciting initiative. Thanks, Katia.
Hi, everyone. My name is Katia. Thank you so much for listening to us. And I just want to invite you to, if you want to become involved in the Hawaii Opioid Initiative at all, that is my contact information. Feel free to just reach out to me and we can have a conversation. In addition, if you have any other questions about the Hawaii Opioid Initiative, please also just reach out to me. I'm more than willing to answer any questions that you have. And that's pretty much it. Thank you for, here are acknowledgements, apologies. But thank you for listening to us and being here today to listen to our presentation. I think we do have a little bit of time. Does anyone have any questions? No? All right, well, if you do have any questions, feel free to reach out to me and we can have a conversation. I'm, again, more than willing to answer anything. And if you want to have any questions for any of the speakers today, I can also forward you their information and we can have a conversation then. But thank you so much, everyone. Oh, we do have, I am not too sure if we have data on veterans, Heather or Andrew. It's something that we can look into and we can get back to you. Jana, if you want to provide your information to us, or send me an email and I can go ahead and see what data we have available.
Yeah, I believe we do have some. I think getting a tripler, for example, in the VA to use the PDMP has been something that's been an important aspect because there's kind of different, confidentiality, there's different policies there. So that's a great question. I think we can get back to you on what we do know. And nationally, we know some things about veterans and hopefully have some of that locally as well. That's a great question.
Perfect. Yes, and go ahead and reach out to us and we can always expand more on that.
I do want to give a plug that the VA was one of the first adopters of naloxone and incorporating it into the pharmacy there. So they were definitely on board early on with getting naloxone to veterans that might be at risk.
And Gary had a question. In the coming year, will you be approaching crystal methamphetamine overdose differently from how you have approached opioid overdose? We are still in the planning stages of how we're going to incorporate stimulants into the Hawaii Opioid Initiative, and that might require a little bit of a restructuring of the Hawaii Opioid Initiative. And as we come together as focus areas, we'll probably identify what route we're going to go through. The important thing to know about the Hawaii Opioid Initiative is that it provides a framework to identify all of the systems and organizations that are already in our SUD systems, and that provides us a framework or a platform to have conversations and allow us to have connections with all these different organizations. So we can update you if you want to follow up with us. We can update you once we start to plan with our focus areas a little more. That was a great question. Thank you.
Could I add something to that, Katya? I think the biggest thing is that pharmacologically, it's very different. So what we just yesterday on our end meth call run by Dr. Mark Baker, we talked about this issue. And so opioid overdose is an acute episode of respiratory distress. So it's literally too much and their breathing stops and there is an antidote, there is naloxone. So that's a very kind of concrete where it looks like most methamphetamine overdose is actually chronic use, heart attacks, stroke, cardiac related issues to a very long term. Doesn't mean there can't be an acute issue with methamphetamine, but at least the physicians that I've talked to and the data seems to indicate that it's more of a chronically long use. And there's also not a drug that revives people. So it's a very different, so you're right, it looks very different and we're gonna have to address it, I think more on a prevention effort and also looking at people along that spectrum. So that's a really good question. They're looking right now, I think there's an OD data that we're gonna have some of the best ever where public health is talking to law enforcement, right, Katya? And UH is coming in, and we're actually having this really integrated dashboard of everything we know about drug-related deaths. And that's the OD2A is allowing that to come together. And so we'll soon be able to answer your question from a data-informed place.
Ooh, we do have another question regarding the pharmacist survey. Are you folks still looking for respondents? I'm going to pass that on to UH.
And I'll answer this. Hi, this is Andrew again. At this time for that particular survey, we did close it because we wanted to collect the results and tally it all up to present. However, going forward, we may have other surveys that we may want to pass through the Hawaii Pharmacists Association. And yeah, I think we don't have anything planned yet, but they were great to work with, and we hope to work with them again in the future. But yeah, thank you for your interest. I hopefully that our future surveys come across your desk as well.
Thank you, Andrew. Is there any more questions? No? All right, well, if you have any questions, again, my information is available to you, and you can go ahead and reach out to me, and I can find the right person to connect you with any resources or to help answer any questions. I want to say thank you to UH and to Heather Lusk and to all of our panelists today for being a part of this presentation and working with me, and thank you to all of our attendees. It's been very awesome, and I enjoyed it. Is there anything else that we need to do before we close the presentation? I'm going to pass this on to our volunteer that helped us. Thank you, Juliana. Katie, do we need to do anything else?
No. I mean, if there's no other questions, I do want to say on behalf of AHEC, thank you folks for joining us today. I know it's a little strange doing the conference virtually like this, but I think we all did an excellent job. So thank you so much.
Thank you. Have a great day, everyone. Bye.